Why don't we just transition into the panel Q&A discussion, and maybe we'll throw the first couple of questions out to you, Leen, since you're all warmed up. And I invite everyone to unmute. And if anyone else on the panel has any thoughts or wants to add their 2 cents to some of these questions, please do so. But I'm going to hand the question and answer session largely over to Sarah and Cheyenne. So, ladies, can you start with the questions?
Yep, the first question is actually regarding this last talk. We had multiple people in the chat asking whether this pro-arrhythmic state due to COVID with the myocardial inflammation may be due to more viruses than just COVID, and whether we should be looking for its involvement in all these other viruses as well.
So myocarditis happens in multiple viruses, like we mentioned. So regular SARS, MERS, influenza, right? So yes, it can be caused by other viruses other than COVID. However, because COVID is such a devastating illness, so like a lot of patients are super sick from COVID, the point is not to miss it, right? So actually people who come in with COVID initially have some respiratory symptoms. 10 days later, 11 days later, they come in and they die, not because of the respiratory issues, because of cardiac issues, because of myocarditis. And that went on missed. It was missed for a long period of time, at least initially, in the beginning of the disease. So all I'm trying to say is, yes, a lot of other viruses can cause myocarditis, but just don't miss it in your COVID patients, especially with the prolonged QT, right? So regardless if they have myocarditis or not, they can still have prolonged QT.
Nice. And regarding arrhythmias from COVID, someone asked, while they understand limited data, are there injuries looking like permanent damage, or has there been full recovery observed after a period of recovery?
So again, great question, right? I would say, so the bradycardias have always been, or the literature has been saying that it's transient, but based on that German study where they did the cardiac MRIs with the 78% cardiac damage in patients who actually had very mild illness, I would say the damage is probably going to be permanent. Now, I know they're probably going to need to repeat that study in a few months or a year to see, you know, we know how it is in the first 2 to 3 months, but what is it in like a year or two? Is there still permanent damage or not? I don't know. But my guess is, based on the case that I've seen, this guy has recovered COVID and came in with new arrhythmias from then. I've certainly heard about a lot of other cases that come in with AFib post-COVID recovery, not just in the acute phase. So I think it's more permanent than we think, except I don't know how permanent. And if any of the other panelists know, please feel free to jump in. But the data is lacking, I guess, or we're still in prematurely early COVID, I guess.
We'll tell.
Let me throw a question out to Leen and also to the group, since this is all about arrhythmias. So one of the issues that has been brought up with the COVID is the prolonged QT. And with the prolonged QT, we always worry about using procainamide or amiodarone in ventricular arrhythmias and ventricular storm. Do you or any of the other speakers have any thoughts one way or the other about, let's say you've got a patient with presumed COVID or known COVID who comes in cardiac arrest? Is your management of that patient going to be any different based on concerns of prolonged QT, or do you just run the standard ACLS, taking into account, of course, Corey's dislike for epinephrine, repeated doses of epinephrine?
I would probably run the normal ACLS until I have an EKG. If he gets return of spontaneous circulation and I have an EKG that shows prolonged QT. But again, like we're talking about somebody who actually had a cardiac arrest. So you can't kill dead from the way I think about it. And so I would probably throw the kitchen sink at them. If they're back, we can always, overdrive pace them, or would I reach out for antiarrhythmics? I might. I will consult cardiology, but I might, knowing the risk of prolonged QT. I don't know, Dr. Slovis, do you have any?
So Amal has spoken about this, and I very much agree. I think amio and lidocaine are probably very, very equal, except lidocaine's class 1B doesn't affect the QT or QTC I would use that rather than amio in one of these patients.
Dr. Steele, Dr. Brady, any thoughts about that? And you both lecture on cardiac arrest as well.
Yeah, I think that I would agree with Leen. I would approach this patient in standard advanced life support for cardiac arrest based on the presenting rhythm. I also agree with Corey that if it's a ventricular dysrhythmia, lidocaine is certainly a reasonable choice here. And the other point about QT prolongation, we actually just finished a review of 600 consecutive patients with QT prolongation and found only 6 arrhythmic events in patients. And it wasn't necessarily related to long QT intervals. So we worry about this. We should worry about this, but I think we worry about it a lot more than we need to. But I definitely would not alter my approach to active cardiac arrest. I would focus on compressions, shocking, shockable rhythm, thinking about an airway, thinking about intravenous medications. If I gave epinephrine, I would not tell Dr. Slovis that. Don't tell him I said that.
Like I said, some of my best friends use it.
We'll keep that between ourselves here. But speaking of Dr. Steele, we have a few questions for you. We apologize that we were having some technical difficulties up front, but some of our listeners were unable to hear some of your excellent responses to questions. So we'd like to throw a few more your way. If a patient looks uncomfortable, but they do have borderline blood pressure, they're not hypotensive, but they're a little soft, and beta blockers and calcium channel blockers are contraindicated, what is your go-to first agent for that?
For atrial fibrillation.
For atrial fibrillation, yes, sorry.
Right. Well, we're assuming that this patient is not appropriate for rhythm control. Is that what we're getting at? Because I always prefer rhythm control, in which case I wouldn't use beta blockers or calcium channel blockers. Is that the premise? That the patient you have to use rate control because it's not safe to cardiovert, and the patient looks uncomfortable. You want to slow them down. The either beta blocker or calcium channel blockers are okay unless the patient's hypotensive, and then I would go with digoxin IV.
And then just to spitball off of that question, when you mentioned the rhythm control with the cardioversion, the questions that our viewers were wondering is how convincing does that story have to be with a time of onset for that atrial fibrillation or atrial flutter?
Yeah, I hear that concern from a lot of doctors who are not used to cardioverting, and they're very worried that they misjudge the time of onset. And in our experience with thousands of cases in our hospital alone, almost always the patient knows exactly when this started. It's not a mystery. They were watching TV and suddenly their heart started pounding, or they went to bed fine and they woke up with their heart pounding. So most of the time it's very cut and dry, and most patients don't sit around at home. Like, they're going to show up often in 12 hours because it's so unpleasant. So the one big exception, I agree, is that the very elderly patient who may not have recognized palpitations, they just feel really weak. And we see this patients come in after feeling really weak for 3 or 4 days, and lo and behold, triage nurse finds that their heart rate's 150 and they had no clue. So that kind of patient where they can identify palpitations, then you have to be careful. But that's a minority for sure.
Dr. Steele, if I can go back to that question just a little bit more, I found it intriguing that you mentioned digoxin, since our current generation of physicians are so. I don't know where it came from, but many of them are just not comfortable or familiar with using digoxin. So let me take this a step back and maybe have you repeat that in a moment. But one of the most difficult patients, I think, in emergency medicine is the unstable rapid AFib patient. and especially if they're in mild heart failure. And a lot of these are chronic AFibers who you just know you're going to shock them and it's not going to work. So in that type of scenario, is that the patient that you're just getting some DIG on board? And I want everyone out there listening to hear internationally known Dr. Steele is mentioning DIG. So if I give somebody DIG, residents, don't give me a hassle for it.
Well, Amal, I've been using DIG for over 100 years.
That's heartwarming. It's heartwarming to hear. Keep going.
No, DIG has been around a long time, and I'm sure the rookies and the newbies aren't used to it. But when I was, way back when I was training, that's about all we had for anything to do with atrial fib, or even SVT, to tell you the truth. So if you have a patient with permanent AF who is going too fast, the first question is this secondary to something else like sepsis or a PE or whatever? And you got to treat that underlying condition. If it appears they've just gone into it recently, then DIG is okay. But if it's a secondary rapid heart rate due to an underlying condition, don't beat yourself up slowing the rate down. Treat the condition. Is that helpful?
Yeah, definitely. That's really helpful. Any other thoughts from the rest? Otherwise, we'll move on to our next question. Corey, you were nodding. I think you might remember DIG.
Oh, I was, when Ian was talking, I was thinking DIG for rapid AFib, which is what we called it rather than atrial fibrillation with rapid ventricular response. And then I used Tensilon for SVT.
Yeah. You raise the blood pressure. How about the ice water bath?
Oh, you got to do it.
We used to do that, and it just amazed the nurses. It's like voodoo.
All right. Well, let's take on some other questions before we get on to rotating tourniquets.
Awesome.
Sarah and
Now,
Let's move our attention to Brady-dysrhythmias. So we have a question. I'll throw it out to Dr. Fix first, and maybe Dr. Hedayati or Dr. Slovis or Dr. Brady, who I haven't heard from more recently, can throw in their answers as well. Do you have any tips on discerning between a high-grade second-degree AV block versus a third degree? It's something that personally I kind of run into a little bit here and there, and I've always been confused about it, no matter how much I read.
Yeah, that is a great question. Thank you so much, Dr. Dubs. And I'll try to explain it. And then if I could share my slides again, I'll show it in a second, if that's all right. So regardless, both of them are concerning, right? Because a second degree type 2 AV block can deteriorate into asystole, and that would be bad. So both of them need a pacemaker. So in reality, you don't have to know the difference if you just think that the patient is having symptoms. So syncope is probably the most common, and especially if they're hypotensive in front of you, regardless of if it's a second degree type 2 or a third degree, they need to be admitted and get cardiology on board and get a pacemaker. Cool. So now that we know we don't have to know, let me try and show you, if I can. I pulled up my slides again just to show you the way that I learned it. So are we seeing this?
Yep.
Good?
Yep.
Okay, so this was the patient that we talked about who had the recurrent syncope, right? She comes in with the orbital blowout fracture. And if I move forward, so this is the second degree type 2. So in this situation, you actually are conducting some of these beats. So that's why your PR interval is actually the same for all of the conducted beats in a second degree type 2, which is different than Wenckebach, which is PR lengthening, and third degree, okay? So you're gonna see P, QRS, P, drop. But when you have the Ps that are actually conducted, it's like either they do or they don't, but the PR interval should be the same, okay? But this is still scary, and you wanna get them a pacemaker. So let's just fast forward really quick to this one, which was third degree. And in this one, remember, you have your P waves marching out to their own drum, and then the QRS is marching out to their own drum. And I didn't show this slide for time, but if you blow it up, and this was the one that the computer called sinus rhythm, which I love. So in this one, you'll see your PR interval changes, but it's not Wenckebach P are lengthening. It's just different because, again, the Ps are going to their own and the QRSs are going to their own. So that is the way I tell the difference between the second degree type 2 and third degree. Is that clear to everybody? Any other thoughts from the excellent panel we have?
Yeah, I think people spend a lot of time trying to differentiate, and the patient is an extremist, and you got 3 people with 4 calipers. I very strongly agree with what you said. You want to treat your patient here, and actually the therapy can be exactly the same. You could push some atropine as you're getting the pacemaker, the transcutaneous pacer.
Totally. Yep. Agreed.
And if you're really in trouble, my bias is to just do a titrated epinephrine drip until you can get to the cath lab.
I will add that if... Go ahead.
One other point to make is that second degree type 2 AV block is the least commonly seen of all 4 forms that we encounter in emergency medicine. And part of its relative rareness is that patients either die or progress on pretty rapidly to third degree heart block.
Right.
So as both Dr. Fix and Dr. Slovis said, let's initiate resuscitation, rapidly look for correctable causes such as hyperkalemia, and move towards some form of pacing. And I do want to put on the record here that we did hear Dr. Slovis recommend epinephrine. So,
as we all know from many of the people we work with, nobody is all good or all bad.
On that note, shifting focus to Dr. Hedayati, we have your comment about cutting the wires for pacemaker-induced tachycardia generated quite some buzz, both among our residents and among the chat box. Can you please comment a little further on the logistics of that?
Yeah, so that's one of those nightmare scenarios that you don't want to encounter. And so that's, to be clear, for a runaway pacemaker situation, which is exceptionally rare. And I am willing to hazard the guess that, none of us have seen that in our clinical practice. So one of those things that you learn about and about, but not something we're going to encounter. But unfortunately, we don't have a therapy for that. You can certainly try putting the magnet on. It is unlikely to work the way it would for pacemaker-mediated tachycardia. And so if you are in kind of one of those life or death situations, then it basically you have to incise over the generator and then cut the wires.
Is quite dramatic.
It's like the movie. It's like the movie Speed. Like, which wire do you cut?
Wow.
Cut them all.
All right. Next question is from Jonathan. We often use amiodarone for rate control and fast, stable AFib when blood pressure limits use of what? When blood pressure limits the use of first-line agents. So, can you explain why you don't recommend its use and why you prefer DIG over amiodarone?
For Dr. Steele, I'm sure.
Oh, sorry. Could you repeat the question?
Sure, no problem.
It's about amiodarone.
So Jonathan says we often use amiodarone for rate control and fast, stable AFib when the blood pressure limits the use of first-line agents. So can you explain why you don't recommend its use and why you prefer DIG over amiodarone?
So amiodarone should not be used in the emergency department for atrial fib, full stop. As I mentioned before, it's very popular in the recovery room and in the intensive care unit where you have very sick patients who also have rapid AF, and amiodarone is helpful at least to slow them down. In the emergency department, our patients come from home. They don't have all this comorbidity, so they're a different kind of arrhythmia. And amiodarone in this case is very ineffective, doesn't work, and it's really slow. I think I said before, it's slow as molasses in the winter, which is pretty slow up here. So there's no role for amiodarone for AFib in the ED. Generally speaking, just to try to get the point across.
One thing to potentially add in is that if you're worried about traditional rate controlling drugs, diltiazem, metoprolol, because of a soft blood pressure, remember amiodarone acts across multiple different mechanisms, including beta blockade, calcium channel blockade, and it will potentiate hypotension as well. If you're looking for a rate controlling agent, I agree with Ian and Corey that digoxin is great. Does take a long time to work, and we all have an attention span that's about that long. Think about esmolol. If you have a soft pressure, esmolol is a pretty good drug with a relatively short half-life. And if you run into trouble, you can back off on it, stop it pretty quickly, and its effect will lessen quite rapidly.
There's also a little bit of literature, and I'm biased and I've done this, using a calcium channel blocker like DILT, but pre-medicating with 1 to 2 cc's of calcium. I've used dilute calcium chloride. I now just drop about a tenth of a milligram of calcium gluconate, put it in 10 cc's, slowly infuse that, wait 2 minutes, and then use DILT. I don't have a large series, but I really like it. It doesn't block the anti-chronotrope, but it does block, it seems, the anti-inotropic effects of calcium channel blockade.
Of course,
Curious to hear your thoughts on whether...
The solution most of the time is just to cardiovert the patient and stop messing around with rate control.
Yeah, I think Ian and the Canadians are too aggressive with cardioversion. However, what Ian is saying here is so true. If you can't decide what to do, then stop dicking around, sedate and cardiovert, and use maximum joules. If you're going to get kicked by a mule, you're getting kicked by a mule. A 5-ton or 10-ton elephant doesn't make any difference. Use the big guns.
150 to 200 joules.
In a patient that's a bit hypotensive, any preference for a sedative? That's a question that oftentimes comes up.
I'd use either etomidate or ketamine. I like ketamine infused in a slow IV push. Patient's going to still continue to breathe. They're going to be amnestic to the event. They're going to have some pain suppressing effect as well. I think it's great. It's not going to cause hypotension. I'd probably go anywhere from 1 to 2 milligrams per kilogram with ketamine. If not, I think etomidate's great. Remember, in about 40% of people that receive etomidate, they'll experience myoclonic jerking. And when we use that in RSI, we don't see the myoclonic jerking because of the paralysis. If you do see it in a situation like this, don't get confused and say, oh my gosh, they're seizing. They're just jerking. That's fine.
I have a question for Dr. Alblaihed. You had mentioned, I guess in the patient that you presented, it was a patient who had apparently recovered a few weeks prior and now is coming in with arrhythmias. Is there a time frame after which we no longer really need to worry about COVID-related arrhythmias, or is there a most common time frame that these are being reported?
The most common is actually during the initial disease. So they can present with it, right? So they come into the hospital because of the palpitations or tachycardia while they're actively having the acute phase of COVID. So I would say within the first 1 to 2 weeks of COVID. Has it been seen later on? Sure, of course it's been seen later on. How common is it? I don't know. And I don't know that we have the data to say how common it is. But again, based on the cardiac damage seen from that study, I would assume it's more common than we think. And I'm hoping there would be more studies out there that would kind of give us a of how common is late arrhythmias, because that's what I was looking for because of my patient. He presented 3 weeks later. So I just wanted to know, is this common? Is it not common? But couldn't find any accurate numbers out there yet. So.
The next question is for Dr. Fix. One of our listeners asked if you've ever seen cardiology try to convert a patient with dopamine out of their complete heart block instead of taking them for pacemaker replacement. Is this common for conservative management?
That is a great question. And And honestly, we haven't used dopamine in the department in a really, really long time. The last time I've seen dopamine is when we get transfer patients who are getting it for sepsis. So no. And I brought up dopamine because it still is in ACLS, and I even emailed ACLS and asked them when they were going to come up with a new bradycardia algorithm. But no, so in general in dopamine, I really rarely ever see it used. And I've never seen cardiology use that in lieu of doing the permanent pacemaker. I have seen cardiology want to discharge a patient who's really stable with generally a second degree AV block, which I really pushed on. I don't know if anybody else has seen that, but I personally don't feel comfortable sending anybody home with a second degree type 2 AV block. So I don't know if anybody else has had that. And if anybody else has had the dopamine question, please feel free to chime in, because I personally haven't seen it.
I've had a cardiologist start patients on dopamine. So I had a Brady-arrhythmic patient who I was transcutaneously pacing and then started meds. But when cardiology came, they're just, why are you giving epi, nor epi, just we'll start dopamine, which I found odd because I've never used it myself. And so there are cardiologists out there that, I guess in the community, because that's where I work, that like dopamine, and the patient did well. I was worried about, because I know it's pro-arrhythmic too, but they said they like it and they use it. So that was my first and last encounter with dopamine.
Great. And we have another pacemaker question. So it was mentioned that patients could be at risk for pacer triggering or sensing issues with fasciculations from using succinylcholine. Is this a broad risk factor, or is there a specific high risk type of patient that you would be more concerned about in this occurring?
Yeah, no, that is going to be a risk for anybody who's got a pacemaker or an ICD. So with the pacemaker, it can cause oversensing, and so then that will cause the pacemaker to stop pacing or failure to pace. And with an ICD, it may actually cause the device to think that there's VTAC or VFib with those fasciculations, and then trigger a defibrillation from the device. So it's definitely something that can happen. And so in those patients, you're going to want to use either rocuronium or vecuronium, whatever you have, if you need a paralytic to intubate.
And while we're on the topic of pacemakers, one more question is, what causes failure to capture in patients with PEA, and how do we treat this?
So failure to capture, again, is where the pacemaker's working, it's firing, but the myocardium is not responding. So there can be a few different reasons for that. So the reason we talked about in the presentation was that the lead had dislodged. And so hopefully, as we progress toward the leadless pacemakers, we'll see less and less of that. But if the lead is in the wrong place, then the pacemaker can try to pace all it wants, but it's nowhere near where it needs to be for the myocardium to respond. And then the leads can fracture as well, so that's another issue. There is kind of a normal process that happens with the leads where it can generate inflammation or fibrosis at the lead tip. And so now we put they have steroids that are sort of embedded into the lead tips to try to prevent that fibrosis or inflammation in the myocardium. But you can imagine, if you've got fibrotic myocardium right where the lead tip is, then that's going to make it difficult for the pacemaker to cause capture. And then, electrolytes, so hyperkalemia is another kind of reversible cause of failure to capture. So we want to make sure we check lights. If the patient is super acidotic, then that can also make the myocardium difficult to respond. And then sort of battery end of life. So if the signal is there, but it's just not strong enough to result in capture, and then that can also lead to failure to capture. In terms of the cardiac arrest situation, if you see pacer spikes and then you see a kind of a normal QRS, but the patient is pulseless, so it's like a PEA situation. And somebody had emailed me this question. Then it's basically that there's an issue with the myocardium. And so there's no cardiac output to generate a pulse. And this is where ultrasound becomes really helpful, is if you can echo the patient and actually see what the cardiac output is. If you have pacer spikes, but there's no resultant QRS, so true failure to capture, then you're not going to know if it's an underlying pacer issue causing that failure to capture, if the myocardium is just dead and is not going to respond. And that's going to be hard. If you know the patient is pacemaker dependent, then I would kind of give it the old college try and try transcutaneous pacing at that point. I mean, that's, put the pacer pads on and see if you can override the internal pacer and see if you can get capture that way. But it's going to be pretty challenging in that scenario. It's a really tough situation to be in.
I have a question for Bill. Actually, Dr. Steele had asked earlier about vagals and adenosine for diagnosing wide complex tachycardias, and you brought up the fact that there are certain types of VTAC that are sensitive to adenosine and sensitive to AV nodal blockers, for example, verapamil. But what about vagal maneuvers? Can vagal maneuvers convert those patients also? And related to that, are vagal maneuvers useful at helping to distinguish between the VTAC versus the SVT with the bundle? Do you know?
Yeah. In general, I think probably not. Are they harmful? I don't think so. I think it's a reasonable thing to consider doing. And, if you've excluded sinus tach because of hyperkalemia, bundle branch block, and toxic rhythm, then you're left with AFib, AFlutter, AV-NRT, and VT. And, again, vagal maneuvers will convert roughly about 20% of AV-NRT, particularly early in its course. The longer it's there, as is true with many dysrhythmias, the harder it is to convert it. So again, that's a small subset of the SVT with aberrant conduction group. Certainly no harm in trying it. But I wouldn't necessarily have a lot of faith in it actually doing the job. And I'm not aware of it interacting with VT in any way, the way the adenosine sensitive form of VT can convert after adenosine administration.
All right, thanks.
All right, we've got a question from Jonathan to the entire panel regarding high-grade heart blocks and mixing calcium channel blockers and beta blockers. It's old teaching that you can cause worsening block. Also, along a similar vein, your thoughts on giving calcium on a patient who's on DIG at home.
Well, I'll just say really briefly, the case that I presented, which was the beta blocker for atrial flutter that went into a atrial flutter with a very slow ventricular response, was due to only metoprolol. So I guess the way that I learned it was the AV node can only take so much. So if you're giving multiple AV nodal blockers, so IV metoprolol, IV diltiazem, and you're not allowing the body to actually, catch up with those multiple IV doses, I've only really seen that happen when there's multiple IV doses. I don't think it matters necessarily if it's either beta blockers or calcium channel blockers. In my case, it was just beta blockers, but again, the AV node can only take so much before it is going to be blocked. What do other folks think?
I think mixing the two is a bad idea in general, and they're synergistic in causing badness. And then as far as calcium and DIG, the case in the 30s was a hyperkalemic patient. Calcium, who had other things going on, calcium and DIG, whatever. If someone needs calcium, give it. If someone needs DIG, call Ian Steele.
Yeah, I would agree with both of those recommendations, and would probably need to publish Ian's phone number here. But regarding calcium administration and hyperkalemia in the setting of DIG, the concern about it promoting asystole is based on a very old article, a case report with really not a great cause and effect relationship established. And yet you see it in every textbook and every article. And when you trace it back to the original reference, it's a very low level of evidence. I agree with Dr. Slovis. If the patient's hyperkalemic, let's give calcium to stabilize the cell membrane and make it less irritable so we can reduce the chance of ventricular badness, or the angry ventricle, I believe it's called.
And I do want to be serious for a second, although I hate to be. I think what Ian said about DIG is really true. It was a drug that many of us used as one of the only drugs available. It is not a great drug, but it should be part of all of our armamentariums. There are specific times to use it, between 0.5 and 0.5, over 5 to 10 to 15 minutes, wait a while. But loading someone with DIG is not a horrible thing, and it may be beneficial in, as Ian said, very selected cases.
And it's still recommended by the Heart Association for rate control and AFib in patients with significant chronic heart failure.
Dr. Steele, since this was mostly pertaining to your talk, do you have any last comments to add to that discussion before moving on to the next question?
Oh, you're muted.
Yeah.
There we go.
No, I'm liking what I'm hearing from these guys. Nothing to add.
Awesome. So moving on to Dr. Slovis, we have a few questions for you about cardiac arrests. The first one regarding the ECMO use and the study that you displayed with the modified Rankin scores at 3 and 6 months. Was that improvement in the modified Rankin score because everyone got better on average, or was it that the people with the higher modified Rankin scores at 3 months were not surviving to the 6 month?
So the people that survived continue to survive. They just got functionally more and more improved. There was minimal variability, but if you make it out of the hospital and are not neurologically devastated, just have a Rankin between 3 and 4, you are most likely to improve. That said, I mean, people that have cardiac arrest and get ECMO and have a refractory VF in general are going to have a significantly higher mortality, short and long term.
And then one more question for you on cardiac arrest. Can you provide any pearls in the treatment of cardiac arrest in children specifically?
Oh, firstly, a cardiac arrest in an 87-year-old that comes in from the nursing home does not induce a high epinephrine state. But a child who arrests after the first few weeks of life, excluding the congenital anomalies and unlikely to survive, it's such a devastating event for everyone. Although I'm aggressive in terminating some adult arrests, I go longer in children. I'm careful in children, and I try to do everything I can and get an ultrasound probe on quickly. That said, if there's no cardiac activity and very low end-tidal CO2 after 3 doses of epinephrine, then depending on the situation, having the parent or parents in the room, showing them that there's no life and no hope of life, I like to stop rather than giving 11 doses of epinephrine.
Yeah, I would agree with that. And I think the other point to make is that we all have much more experience, fortunately, odd way to say it, in treating adult patients with cardiac arrest. And remember, in the out-of-hospital world, fully 3/4 of those patients are having some sort of cardiac-based event causing the cardiac arrest. Obviously, the exact opposite is the case in children. So look for correctable causes. Look for the cause. Is it airway? Is it volume? Is it electrolyte? It is very rarely, it can be, but it's very rarely a primary cardiogenic cardiac arrest.
And if I could, I totally agree. Narcan. It has no toxicity in cardiac arrest. And some kids have respiratory arrest due to narcotic overdose, have a PEA arrest, and it's unrecognized as to the cause. So we give it early in both adults and children in PEA arrests.
Dr. Slovis and anybody else who wants to throw comments in, I know, Corey, you're not aggressive about giving epinephrine. You mentioned 2 or 3 doses of epinephrine. What if you get the pulses back and the patient's kind of chugging along and then they re-arrest? Do you start over again with up to 3 more doses, or do you feel like you've already maxed out?
No, Amal, that's a great question. In VFib, I would not administer more epinephrine. I would use beta blockade. But I think for asystole and PEA, epinephrine may be the only thing that gets you back going again. I just be judicious, but no, they've gotten 3 of epi and they rearrest, time to restart. I don't know what other people think.
I'm seeing people nodding in agreement. So I think we probably have about time for one more question before we wrap it up.
This last one will again be for Dr. Hedayati. We had, if you can just review for a lot of our listeners, the use of magnets in pacemakers. How quick does it take effect? How quick does the effect wear off when you take it off? And what does a defibrillator versus a pacemaker revert to when it is removed?
Okay. So the magnet turns the sensing function off for both a pacemaker and for the ICD. It's just that what the effect of turning the sensor off, the sensing function off of those devices, the after effect of that is different. So for the pacemaker, when you turn the sensing function off, the pacemaker stops looking for normal or abnormal rhythms and it just paces. And so putting the magnet on a pacemaker causes the pacemaker to work. When you put the magnet on an ICD, you turn the sensing function off again. But with an ICD, it's looking for VTAC or VFib. It's looking for dysrhythmias that it can cardiovert or defibrillate. So if you turn the sensing function off on an ICD, it's not going to detect VFib or VTAC. And so then it will not cardiovert or defibrillate. So that's the difference between the magnet on a pacemaker and the magnet on an ICD. Now, when you put the magnet on the pacemaker or the ICD, you want to put it directly over the device. If you have a patient that has a lot of subcutaneous tissue, then you may actually need to stack the magnets. So you may need 2 magnets. And so you can stack those and then tape it down to the patient's chest so that you can go ahead and do whatever else you need to do and not stand there holding the magnets. The magnet should work pretty immediately. So you should see if you put it on the pacemaker should fire up and start pacing. And you'll see the effect at that point. And then what you can do is then okay, the pacemaker is back online. Maybe it was an issue with oversensing. Maybe there was some sort of electromagnetic interference. Something happened that confused the pacemaker and now it's working fine. And then you can go ahead and take the magnet off and then see what happens. If the pacemaker is back online, everything looks good, you're essentially done at that point from your standpoint. You still may want, if you have the ability to interrogate in-house, you can call the cardiologist to come bring the computer down and do that, or you may need to call the device manufacturer rep to come in and interrogate the device. But at that point, you're done. If you take the magnet off and then the pacemaker sort of dies again and stops working, then you know that there's some sort of issue with the battery or some part of the component. And so just put the magnet back on again. And then you need to call the electrophysiologist in because they're going to need to troubleshoot sort of on a higher level what's going on with the pacemaker.
All right. And I think with that, let me just make some closing comments. First of all, I want to thank all the people who made this conference possible. Doreen is out there still monitoring the chat and answering questions. Michael Bond for running a great show. I'm glad we were able to work out the sound effects. And also Tim Frazier, who's really a tremendous help here as well. Dr. Sarah Dubbs and Dr. Cheyenne Fallett for running the chat. I really appreciate all of your help. And also, I don't want to forget Dr. Brian Brown. He's our chairman, who has been nothing but 100% supportive of every educational effort that this department has ever pushed forward. And that's why we're able to run this conference. And then finally, my sincerest heartfelt thanks to the speakers for putting together some really great presentations and donating their time to education all around the world. Dr. Steele, Dr. Hedayati, Dr. Brady, Dr. Slovis, Dr. Fix, and Dr. Alblaihed. These are some really, really great talks, and I really hope to work with you all in the future. For all of the attendees, thank you so much for spending your time with us. And we'll make sure that you have access to the full audios of the Zoom. I know during about the first hour or so, there was some audio issues, but those are not present on the YouTube that you'll be getting access to. And again, thanks so much. We do have some conferences coming up that are flashing across the screen. And also in the fall, we'll be announcing when our next Crashing Patient conference is going to be. And as you see up there on June 16th, we'll be running a critical care symposium within our conference as well. Please stay well, everyone. And, I hope to get beyond this Zoom and pandemic before long and get a chance to see and meet and shake hands with everybody, or at least give a fist bump to everybody out there who was able to join us today. Stay well, and best wishes to all of you. Thank you all very, very much.
Thank you.